All right, let's go ahead and get started. Thank you all for joining today. First, I want to just provide a very brief overview of our Prevention Research Center. So, for those of you who are new to us, the Prevention Research Centers are a network of CDC funded academic research facilities in the United States that study how people and their communities can avoid or counter the risks for chronic illnesses. Our PRC at Georgia State University is headquartered on the Clarkston campus at Perimeter College, and we work with community organizations, state and local governments, residents, and other partners in Clarkston to develop, implement, and evaluate culturally and linguistically responsive interventions to address disparities and determinants of health for migrants and refugees, and then to disseminate that work at the community, state, and national level. Today, I am so pleased to welcome two experts in their field to talk with us a little bit about their work. So first, we will have Kafuli Agbemenu, and she is an assistant professor at the School of Nursing at the University of Buffalo. Her research really focuses on examining reproductive health outcomes of African immigrant and refugee women. She conducts research on culturally congruent family planning, education, contraceptive decision-making and uptake, pregnancy outcomes, HIV stigma reduction, and access to reproductive healthcare services for African immigrant and refugee women. And she's going to talk a little bit today about a smartphone-based contraceptive use educational intervention for African immigrant women with low literacy. I'm also pleased to welcome Adebola Adegboyega, and she is also an assistant professor in a college of nursing at the University of Kentucky. And her research really focuses on health promotion, cancer screening and prevention, and reducing health disparities among underserved and minority populations. And a lot of her work has focused on promoting breast, cervical, and colorectal cancer screening among African American, sub-Saharan African immigrants, and Appalachian Kentuckians. So they both have a lot to talk to us about today. And she's going to specifically talk about cervical cancer screening in sub-Saharan African immigrant women. So thank you both for being here today. We're so excited to hear your presentation. I'm going to stop sharing at this point and turn it over to Dr. Agbemenu.
Thank you so much for that introduction.
You.
Let me go ahead and find my presentation. Okay, can you all see that?
Yes.
Thank you again. So my presentation today will be a little synopsis summary of the research that I am conducting right now. As was mentioned, the research I do revolves around these topics here. At this time in my career, I'm primarily focused on contraceptive decision making and uptake. And we're designing an intervention to assist with that piece of education. So a little bit about why I'm conducting this research here in Buffalo, New York. There has been significant refugee resettlement since 1975, and Buffalo has resettled refugees for the past 15 plus years now. With upstate New York, we are sort of Western New York, resettling about 95% of those refugees, and African refugees account for 23% of the numbers resettled. I always like to mention in my presentations that refugees are legally eligible to work in the US, have received clearance after very extensive medical clearance. And we, at least in the Buffalo region, we do expect to see increasing numbers of refugees being resettled. As such, it is important that we focus on improving their health outcomes. When we think about African refugees in the US, other reasons why I do this research, because we know that they endure these overt and subtle degrees of discrimination due to minority status and others. And I think we can see a lot of that right now in our communities, with people coming into the country and some resistance against that. There are numerous cultural, religious, educational, economic, language, social, and political barriers that impede potential healthy outcomes that need to be addressed. There's also the concern, the issue of dual discrimination from minority status and being from a minority racial group. These layers impact health outcomes, other reasons why I conduct this research. So in the next few slides, I want to tell you a little bit more about the work that I have done that has inspired the work that is going on now. In some of my studies, I have found that, we know that unintended pregnancy is associated with poor maternal and infant outcomes. Some of my work has revealed that, at least in the sample that we looked at, unintended pregnancy rates were 30% higher than in the general population. Also, in conversation with the population, there's been a request for a culturally informed family planning educational intervention. So that is the work that I am doing now. Just sharing original study aims that we are adapting an existing web-based intervention into a culturally congruent family planning, smartphone-based intervention. And then once we develop the intervention, we'll be testing it for feasibility, acceptability, and preliminary efficacy. Some of the methods we've used to achieve this goal, there have been several studies, but have included, translational research approaches where we're integrating data from multiple studies, and that's informed the development of the intervention. Some of the methodologies include a scoping review. When we started this work, honestly, we found very little about African immigrants and African refugees. So we had to start at a foundational level. It's not as if we're conducting research on diabetes in the US where there's a lot of data. So we started off at that foundational level again, doing scoping reviews. There was a secondary data analysis of birth certificate data. We convened a community-based advisory board at one point to tell us about the needs of the community. We've had qualitative studies, and right now I'm actually doing a cross-sectional survey where we are examining contraceptive intention in the wider African immigrant community. So the next two slides just list out some contributing studies to where I am now, the work we have done in the past. We did work on reproductive health experiences of Somali Bantu women. And from that study, that sort of gave us, I would say, foundational knowledge about contraceptives in that community. There is sort of a perception that Somali Bantu women tend to be Muslim women, and there's a sort of a perception that they are not interested in contraceptive use. However, in that study, we did see that they were interested. However, there were concerns about side effects or concerns about acceptance, family acceptance of using contraceptives, and other concerns. We had an obstetric intervention study, or avoiding obstetric interventions, and in that study we saw high C-section rates that did not seem to be very medically indicated. So again, with that one, it said to us that maybe one of the ways to mitigate these high C-section rates would be to space out pregnancies. And if they're spaced out, the mothers would be healthier, the infants would be healthier. We conducted a family planning trends in African refugee women study, which was the same survey that provided the HIV attitudes data. And for example, in the HIV attitudes data, we asked questions like, can you contract HIV from sharing a spoon with someone who has HIV? Or can you get HIV from a mosquito bite? And there were some people who said, yes, you can contract HIV from a mosquito bite, which again indicates to us that we need to do some education around, transmission of the virus, the ways that it would actually be transmitted. And then, here even more studies, again, informing the work we're doing now. We had a conversation with men in the community about family planning methods. And that's why the one is titled Vasectomies Are Evil, because the one gentleman shouted it out, and then we had another conversation about, what does it mean if you have a vasectomy? How are you taking care of your family in that way? And then I'm not going to elaborate on these other studies, but just again to let you know that it has taken a significant amount of work to get us to the place where we are now. An interesting aside about the WhatsApp study for Ghanaian immigrants, and we're talking about HIV stigma. It was noteworthy in that study that, first of all, we had more men than women in that study, which is unusual. And in that study, for example, men said to us, if I had like an extramarital partner, I would use condoms with this partner, but I would not use condoms with my wife. And then again, that is informing the family planning education that we're going to put together, because it exposes people to different risk. I want to talk a little bit about my challenges with recruitment and enrollment so far. They are the challenges of the history of research misconduct and human subjects abuse. That is a prevalent one. I mentioned Tuskegee here for more the US audience. And then we see different incidences in African countries that really lead to distrust. So that was a challenge we had as well, establishing trust with the community. And then just a fear of breach of confidentiality. So we had to educate the community on, information is collected in aggregate, your information is safe. We use non-standard approaches for recruitment and enrollment again. I always think it's interesting when I am putting together an IRB protocol, I always design a beautiful flyer that we never use, but that's what the IRB requires versus what the community requires, because it's word of mouth. And then another challenge, this is a map of Africa and the predominant languages that are spoken. Africa as a continent speaks, over 3,000 languages. So how do you overcome that? How do you develop a culturally relevant intervention that appeals to a larger part of the population that they will actually understand? And that's the work we are doing now. And then fear of stigma again. So some lessons learned really quickly. Building relationships, obviously, gender concordance and cultural competence, the dress, the language, the colloquialisms, everything that's needed to appeal to the population. Flexibility, I say flexibility in terms of research timelines. It's taken significantly longer than I anticipated to do every single thing. And then just subtle visual nonverbal cues that we're sensing from people as we engage with them. A language, local dialect matters too, because I speak Kiswahili, for example. I grew up in Kenya, and then I work with Congolese population, Somali Bantu. We are all speaking Kiswahili, but it sounds different dialects to some extent. So before we started off developing the what I'd say the big family planning intervention, we started off with prototype development, which involved again community boards. We had a board for women, a board for men, realizing that we needed to have separate groups so that we could have very frank discussions. And then we traveled to Kenya. The photo on the one side is a still shot from our filming in Kenya, because we needed someone with linguistical capabilities. And we needed linguistical capabilities from the actors and from the video production company, which was difficult to find in the US. I don't know if we have enough time. I wanted to share a little bit of the video, but if we don't, if anyone is interested in seeing the prototype, I'm happy to share it with you. We are still testing it. We're still testing it right now. So I don't have outcomes yet, but preliminary results indicate that the community find it acceptable. We've shown it to our advisory board. And the advisory board were also instrumental in helping us develop the script. So they say that, content is good. It's about 13 minutes long, and it's a discussion between husband and wife about family planning, and it's a discussion with the husband and a friend of his about family planning, and we add all these elements to ensure acceptability. What happens next? We got funding from the NIH in an R21 to develop even more modules. We're calling them modules of the intervention. So it will be sort of a series talking about different aspects of family planning. And that's pretty much it from me. I want to acknowledge the funders for the prototype study, and the NIH has funded the extension. My community partners, I partner with an organization called Jericho Road here in Buffalo. My good friend Francine Roanica helps me very closely with recruitment. She speaks 7 languages. Without her, we could not get this work done. One of the studies I mentioned, we spoke 5 languages to get it done. 5 languages, 1 year to recruit 100 women. So very time-intensive work. And I just want to acknowledge my R21 team, a very interdisciplinary team. We have communications, public health, OBGYN, cybersecurity, social work with reproductive justice perspective. We have our statistician, and these are all the team members you need to get the job done. And I want to acknowledge my student team as well. Again, very diverse disciplinary-wise. We have nursing, we have public health, global gender and sexualities. We have global health. So just, it's a team effort, as you all know. And I don't know if we're taking questions now, but that's my, what do they call it? I forget the name of it, but you can scan that for a list of my publications if you're interested in finding out more. But thank you so much.
Thank you so much. Yeah, I think, why don't we go ahead and transition to our next presenter, and we'll save questions for the end. I have a few already in my head for you. So looking forward to some shared discussion. All right. Yep. Looks good.
So, thank you. Thank you for inviting me once again. And thank you, Dr. Kafuli, for your presentation. Very interesting work. So I'll be talking about my ongoing project promoting cervical cancer screening for African American and Sub-Saharan African immigrant women. I'm trying to advance my slide and it's not advancing.
Maybe try like the page down or arrow on your keyboard.
I'll try that. Oh,
there we go.
Thank you. So these are some of the things I'll be talking about. I'll talk about how I got interested in cancer disparities research, say a little bit about the background of the study that I'm doing right now, then talk about some of the formative research that I've done to support this work, and talk about the current study and some of the lessons that I've learned. So my interest in disparities research actually started because I thought I was an insider researcher, but I'm going to talk more about that when I talk about lessons learned. And as an immigrant from Nigeria, just coming to the United States, I discovered that it was when I got to the United States that I knew that I was Black for the first time. Growing up in Nigeria, it was never a thing for me. I never really saw myself as Black. I just knew this was me. But when I got to the United States, I discovered that, oh, I'm Black and I'm in the minority. And as a nurse, I begin to see the disparities that minorities that they have. You know, when you look at data, and even when you look at the hospitals, you see that Blacks, they tend to have these high incidence of different types of diseases, be it diabetes, be it cancer, cardiovascular disease. So it's like they had a lot of these diseases. And when you look at the data, it's not really disaggregated, like they are just all put together in one group. And so this was something that sparked my interest, and I wanted to learn more. So when I started my PhD, I decided to do a study on African immigrants. So my PhD study was focused on promoting pap screening among African immigrants. And when I looked in the literature, there was really not a lot. And that's not too far ago. I mean, that was like 6 years ago. And there was not a lot of information. And so this was something that fueled my passion to do cancer disparities work. And in doing this work, I wanted to identify and address culturally driven determinants of health outcomes. I wanted to identify if there were differences even between the races, and also wanted to understand how migration might have impacted cancer screening and other lifestyle behaviors. So just looking at the background of my study, about 93% cervical cancer can be prevented, maybe through regular screening or through HPV vaccination. So most of the women that are diagnosed with cervical cancer, they've never been screened. About 50% of them have never been screened. And subgroups of Black people, they don't participate in screening. And the group that I listed down here, I think I have like 5 groups listed down here. And these are the subgroups that they don't receive recommendations for screening. They don't undergo timely diagnosis, and then they don't have timely treatment, which many of them have poor outcomes. So the groups that are highlighted in red, they are the groups that I've worked with in the past. So racial and ethnic minorities, rural residents from Appalachian Kentucky, and of course, immigrant groups. So I'm going to say some things about the Black immigrant groups in the United States. The group is increasing. It has since doubled since year 2000. And this group of people are from 2 regions of the world, majorly. So about 88% of them are either from Africa or they are from the Caribbean countries. Then the remaining 12%, they are from Mexico area. Specifically about African immigrants, like you saw in the previous presentation, it's a very diverse group. So there are 54 countries in Africa, and when they come to the United States, we are all put together as African immigrants, but we are very diverse. And this is also a growing population. There has been a 16-fold increase since 1980. So talking about the research gaps that I noticed as I started to do this work, like I said, I discovered that Blacks are usually categorized as one group. Despite the diversity in the group, there are diversity in different areas, even in the languages spoken, in the culture, in the background, in the lived experiences. So there are diversity. Then, of course, the subgroups are usually underrepresented in trials. And when they're included in the trials, they are too few that a conclusion is not being able to, they don't make a conclusion about that group. So maybe assuming there's a trial of 500 people and there's just 30 African immigrants, there's really nothing much you can do with that number because there are too few. And many of the interventions lack cultural appropriateness. So the study population that I focus on, like I said, I focus on African Americans and sub-Saharan African immigrants. And I decided to focus on these 2 groups based on some of the reasons that I've given before. And this group of individuals also have incidence and mortality rate for cervical cancer. So the incidence rate among Black is 8.8 compared to 6.9 among the white population. Even though the incidence rate for Hispanics is higher than that of Blacks, the mortality rate for Blacks is higher for all groups. So mortality is 3.3 for the Black population, whereby I think it's about 2.5 for the other group. And of course, this group of individuals, they are at risk for getting cervical cancer. They have high rates of HPV infection, low HPV vaccination rates. Even though when they start the series, many of them don't complete the series of HPV vaccination. And then there's lifestyle risk factors, especially for individuals that are migrating from Africa, because of the risk that they already face in Africa. And once they immigrate to the United States, they tend to bring that burden of risk with them. And then they don't get screened on time, so there's delayed screening. And when there's abnormal finding, they don't usually follow up. And so this leads to late diagnosis where the treatment outcomes are usually poor. And these groups also have very many barriers to accessing healthcare. There is negative past experience. There is fatalistic beliefs. Some of them is just because they are not able to attend the clinic hours at the clinic hours because of the type of jobs that they do. And of course, for African immigrants, their immigration status, or the fact that they are foreign born, that also affects their screening. I don't know what's wrong with my slide. It's taking forever to advance. So this is one of the formative work that I did leading up to this particular study that I want to talk about. So for this particular study, we wanted to use HPV self-sampling based on some of the previous work that we've done with the group. So for many of them, it's not being able to go to the clinic because of the limited clinic hours. And also for some of them, it's just the pap screening procedure was kind of too, I would say, too personal or too private. They wanted something that would give them the opportunity where they don't have to be in that vulnerable position. So I thought about using the HPV self-sampling, which is, it's not new, but it's an emerging technology that's been examined in research in other countries. But in the United States, it has not been approved for clinical use. But of course, we know that HPV testing is one of the modalities for cervical cancer screening. So in this formative research, we asked them about their willingness to use the HPV self-sampling, and these were some of the things that they said. If detailed instruction is provided, if they are not going to be used as guinea pig, if it's going to be free. So they were willing to do it. And of course, some people were undecided about doing this. Then some people talked about their confidence and their ability to self-test. Some of them were concerned about if they were going to do it correctly, they needed some supervision, or they wanted us to show them how to do it. Then for the results, that was a big thing. Some of them, it's like, oh, if it's positive, I don't want you to just send me an email with that result. I want to be close to somebody who's going to help me navigate what I need to do next. And then we asked about some suggestions on how to address their concerns. So many of them suggested that we include videos, infographics. They wanted a female personnel to be the one that would deliver the intervention. And then for the delivery method, this was supposed to be done in churches and a library throughout Kentucky, but then COVID started. So we had to change everything to online. So talking about the current study, it's a two-phase study. And the first phase, we did a cross-sectional survey to examine factors impacting cancer screening in general. So this study included 196 individuals, men and women. Then there was also a mixed method study that we used to guide the adaptation and development of the intervention that we're going to implement in phase 2. And phase 2 was a study where we're going to evaluate the feasibility, acceptability, and the preliminary efficacy of our intervention that we call Health is Wealth. So I'm going to go through how we did like a cultural adaptation, because this intervention was not developed from the scratch. Like we say, there's really no need to reinvent the wheel. So we found this intervention is the gateway to health, a cervical cancer screening program on the NIH website. So they have a deposit where they put all the interventions that have been tested and that were found to be efficacious. And so we found these and we contacted the developer. So this was an intervention that was developed for Korean women, and it was to promote Pap screening. So we needed to adapt this culturally for African American women and African immigrant women. So we are working with 2 different groups here, and then we are introducing HPV self-sampling instead of Pap screening. So these were some of the things that we did using the framework from Barrera. We did some information gathering. Some of that I shared on the previous slide. We did some preliminary adaptation design, then some testing and further refinement. So for the gathering, we did focus group to inform the changes. And then for the adaptation of our design, we got input from cancer control prevention experts and one behavioral researcher. And then for the testing, we got 4 women, 4 African American, and 3 sub-Saharan African immigrants. They received the education that we developed or that we adapted. They gave us some feedback. We did more work to refine that, and we came up with what we call Health is Wealth. So because we had 2 groups, we did like a group tailoring to make sure that we were tailoring the intervention to each of our groups. So sub-Saharan African immigrant women, they had a particular intervention changes. Then for the African immigrants, for the African American, we did some other changes just to make sure that these were culturally appropriate for them. And so what we did was we included case studies. So for each of the group, we included 2 different case studies based on the cultural beliefs and the common experiences that they've had in the healthcare. So for that part of the study. And then as part of the education, we addressed the barriers that were specific for each group. So for African immigrants, for example, they talked a lot about language. And so that was something that we had to talk about during the intervention, like the language. If you think you need an interpreter, you need to advocate for yourself. And if you don't need an interpreter, once you get there, you just tell them you don't need an interpreter. But make sure that you speak up, because African immigrants, we don't really advocate a lot when it comes to healthcare. We just accept whatever the provider tells us. So we coached them on some of those things that they needed to do during their healthcare encounters, and we ensure that the reading level of the intervention was at the 5th grade level. And we use very short and focused messages. We included relevant graphics and images. And of course, relevant statistics for African Americans, because that statistics is available. The statistics for African immigrants, we included data from Africa, just to say, this is what you're working with. Even though you're here, you still carry some of this burden with you. So this is the front page of the manual. So it's Health is Wealth, a cervical health program. And it was not a clinical trial because this was a key award and the budget was limited. We had 60 participants, 30 African Americans and 30 sub-Saharan African immigrants, 30 to 65 because that's the recommended age for HPV testing. And this was delivered by a lay health worker, a community health worker. And this was done in groups. So we had groups for African Americans, group for African immigrants. And like I said, it was done online because of COVID at that time. And the education was 1 hour. Then we provided them with a self-sampling kit and the instruction. We are collecting data because we are not yet done with data collection, pre, post. At 1 month, we did a one-on-one interview with them to find out how they're doing with the kit. Did you complete your testing? What issues are you having? Then the 6 months data, some of those are still ongoing. And these were the outcomes that we were looking at: completion of the HPV self-sampling. That was our primary outcome. And we wanted to find out the effect of the intervention on their self-efficacy, the knowledge, attitude, and beliefs, and if the intervention helped to mitigate some of the barriers that they think they experience. And for individuals that have a positive HPV test, we provided some navigation. So talking about some of the lessons that I learned, when it comes to recruitment, I think it's important to leverage community organizations and go to events. And mostly, I'll say churches, faith-based organizations are a good place to recruit, also identify partners and build trust. Then if there are other researchers within the network, you want to leverage their network and connect with the people they are working with, their partners. Then there's a caution on online recruitment. There are so many scams out there. You want to make sure that whosoever you are enrolling, you've seen them over video and you're really sure they are who they are. Because once you put all these on social platforms, you get a lot of it. And by the time you start reaching out to them, it's like, these are not real people. Then for engagement, I think it's important to make sure that there are different options for them to complete data. You can even help them be on the phone with the question and complete the question at the survey on your side for people that have limited literacy. Communication, I think WhatsApp is a good way to reach out to African immigrants. For African Americans, they do well with texts and phone calls. For this group, I don't think email is very good because you don't get any response back with email until you follow up with a text or a WhatsApp message. Then you have to ensure the confidentiality of the results and research procedures. That was a major challenge because this was something that was very personal. Some people were even concerned, what are you going to do with my sample? So I had to tell them, I'm not even getting your sample. The sample is going straight to the lab. So just assume you're going to a clinic to get something done. You don't ask them what they do with your sample afterwards. Then flexibility of intervention time. And we need to be mindful of participant burden because many of them, they will be interested to be in the study, but by the time you tell them, oh, you're going to complete the survey and it's going to take approximately 15 minutes, many of them is like, I don't really want to do that. It's taking too long. And then the type of information you are asking them to provide, people are very sensitive when it comes to provide your country of origin. If you were not born in the United States, how long have you lived in the United States? They're really concerned. Why do you really need that? And then, so talking about being an insider researcher, I guess I was wrong. When you say you are an insider researcher, I think that does not mean, even though I'm Black and I'm an African immigrant, it doesn't mean that I have a depth of knowledge about the culture, because I only speak one language. I don't even, I speak an African language, but it's not a popular one. So I'll say I only communicate in English with most people. So it's important to be open to feedback, and you want to engage with the community leaders. And as we've said all along, it's a very diverse group. So we have to be cognizant about that. And then confidentiality is very important. And what I found is African Americans they have more mistrust of the system, while African immigrants is more about the personnel. It's like, who's going to see my stuff and things like that. Then for community service, as a researcher, you want to give back to your community. Make sure you're sharing your findings, provide incentives for the participants. If you have partners, provide them incentives. It might not only be monetary, sometimes it's just showing up when you're not asking for letter of support or when you're not recruiting, just show up. Then, of course, it's important that the team should reflect study population. So it's important to have interpreters. If I'm going to do this over, I'm going to have interpreters, because I think many of the group that I would have been able to engage with, many of them were not willing to be in the study because it was in English. Oh, sorry about this. I don't know. It's not going for that. Is it doing my slide? Let's see. Okay, I can't advance it further, but I think it's probably
It freeze on you or something.
yeah, I think it did. So it's not going further, but I think I'm at the end of the slide, just a couple of acknowledgements and stuff like that. So get long-term commitment from your team members. I think people like it when it's the same faces that they see all the time, rather than have somebody come today, then another person is calling them over at the phone. So I think I'll stop there. It's not going any further. So sorry about that.
No worries. That was a really rich discussion of lessons learned. Lots to think about. Thank you both. For our attendees, if there are questions or comments, feel free to use the Q&A function while we wait to see if there are questions from our audience members. I have a couple. Actually, I have a lot of questions. I'll just start with one, and then I will, it looks like Simrat has a question. So I'll start. Gosh, which of these questions to start with? Well, maybe just because you just mentioned this, Adebola, you both talked a lot about the diversity among African immigrants, right? How many different cultures, different languages, even within the same language, different dialects, and the complexity of that. In our refugee resettlement community in Clarkston, Georgia, we have experienced this exact same challenges. I think there are like 68 different languages spoken in Clarkston alone, which is only 1 square mile. And I wonder if one or both of you could talk a little bit more about how you've addressed that, how you tried to tackle that challenge. It's both such an advantage, right? Because there's such incredible diversity of perspective, and that's such a lovely quality in a community. At least for us in Clarkston, that's certainly true. And it's also a real challenge when you're a researcher. So I was wondering if you both could talk a little bit more about that and how you've attempted to address that in the development of your interventions.
Yeah, so I mean, I can start, like you said, I think it's an ongoing work. It's something that I keep thinking about all the time, like how am I going to get this done? But I think just engaging with the community more, like using community advisory boards and getting feedback from them based on the preliminary material. That usually helps to address some of the issues that might be applicable to this group and not applicable to this other group. So, for example, in the Lexington area where I live, it's the we have the highest resettlement for Congolese in Kentucky because of the Kentucky Refugee Ministry. But the challenge engaging with that group is because I don't speak French and I don't speak Swahili. And so I've not really had a lot of that group in my study. Most of the group that I've had in my study are groups from English-speaking background, just coming to the United States, or people that are comfortable speaking English. So that's the group that I've been engaging with more. But going forward, something that I've been thinking about is if I really, really want to go deep down and reach this community, then I need to really have interpreters for my study. I need to be able to develop and translate all my study materials and my surveys. And that costs money, that costs a lot of time. And so because I was doing like a career development award, that was not feasible. But once I get the preliminary data and I'm submitting a larger grant, that's something that I'm looking at. And also I'm open to be able to do like subgroup analysis to just see what's really the difference between these groups.
Yeah, great points. Kafuli, would you like to add anything?
Sure. So for me, one of the ways we have dealt with the language challenges is we've sort of narrowed down the populations that we can work with for now. I'd mentioned in some of my research, we spoke 5 languages to get the study done. And then after that, decided that maybe we can focus on majority language. And in the Buffalo region, Somali, Bantu, Congolese, people from Burundi, a lot of them speak Kiswahili. So I made my research align with their language as opposed to trying to find many languages. There was also, so again, the study with the 5 languages, one of the languages is a language that is not written. And, if the language is not written, that would hamper things even more. So we stuck with Kiswahili. I speak Kiswahili. So for now, that's what we're doing. And then hoping with more funding that we can expand to other communities.
Thank you both. Yeah, you certainly touch on a couple of issues that resonate with us in our work. Adebola, the comment about how time intensive and resource intensive it is to do this work well. I think we have had a very rude awakening in some of our work, and with our budgets, we've really needed double or triple the amount of money that we had initially allocated for interpreters, translators, the time that it takes to do it well, to get something translated, then back translated. Then we also have had local native speakers look at it from kind of a cultural appropriateness lens, and the specific words that are being used, like, is this the right word in this context? And I do feel like everything takes twice as long as you think it will. And yeah, I think Kafuli, your comment about narrowing the population, I think we've also learned how important it is to do fewer languages well than try to do many not as well, right? I see we have a question from Simrat. Let me unmute you. Go ahead.
Hi, good morning, everybody. Thank you so much for such an educational presentation. My question is, in regards of the first presentation, it was said that, the female they usually go for a C-section so that there should be a gap between the two pregnancies and they stay healthy. So my question is like, is it like a usual practice that every female go for C-section, or the one who really needs C-section goes for C-section?
So that's a great question, and also very difficult to answer because we were interviewing the women, and according to them, they felt that C-sections were not indicated as often as they were receiving them. They felt like the doctors were sort of pushing them towards getting C-sections, and they felt they didn't need them. However, that said, like I mentioned, okay, you have a C-section and body needs time to recover. And ideally, if you're able to space out pregnancies even more, you have better outcomes. So not just recovery after the C-section, but also just waiting a little bit longer. That's what we found. Yeah.
Oh, thank you.
Thank you. So we have a few more minutes. I have a couple of other questions. I'm just pausing in case any of our attendees would like to ask a question. I feel like I would want to talk to you guys for another hour. I wonder if maybe we could end with a reflection from both of you about what surprises you've had in this work so far. Both of you have been doing this for a while, but it seems like these specific projects are in progress and still fairly new. So you may not have any surprises for the specific project that you presented on today, but I wonder if in your work that's related in this domain and working with these specific populations, do you have any surprises that you weren't expecting?
Yeah, I mean, I can start. And like I said on my first slide, that I thought I was an insider researcher. Yeah, so that was surprising to me because I thought, oh, it would just be easy breezy, just working with this group because, of course, I look like them. For most of them, I speak English like them. And so it would be very easy to do the work. But I was really surprised because they tend to even question me more because some of them are people that probably know me personally or people that have seen me around. And so they're more concerned about what's going to happen to the information that they are giving me, rather than if it's somebody that they don't know. So they don't really have that connection, or they feel that this person will never really know who they are. But because we live in a small community, it's like, oh, she knows me. So if I do this test and my test is positive, what's really going to happen? So that's been a challenge to just let them know that even when this is published, your names are not going to be included. And as you're submitting your sample, you're submitting them to the labs, and your names are not even included. We're using unique IDs that is not linked to your name. And so it's been very surprising to see how people are very, very protective of their information. So when maybe I consent somebody and then I send them like the survey, once they see the first few questions, like, just like, I don't really want to do this anymore. It's like very intrusive questions. And those are just like demographics, because that's what I start with, rather than when it goes into the specific measures. And so that's been really surprising. And I think our community need a lot more education about research and what it means to be in the research. Because when they hear about the incentives, they are excited. Oh, you're going to get $30 for completing baseline. Then maybe 1 month's follow-up interview, you get another $20. And in 6 months, we'll call you back, you get $40. They're very excited. Oh, yes, sign me up. But then when it comes to the process of going through, you just have same people falling through, they don't really want to do it because they don't want to put in the time. So I'll stop there.
Yeah, great points. Yeah, Kafuli.
Yes, so I would definitely echo what Bola has said in terms of the complexities. I would say, at least for me so far, I haven't been surprised by much. However, when I received the R21 and I was very excited, new NIH funding, there are different levels of complexity with that level of grant funding. So for example, we were having a conversation, I want to travel to Kenya to work on this project. First of all, there is a foreign exclusion. I cannot pay monies to a company in another country. And there were even instructions on the planes that you can fly. There is a Fly America First Act. And so if you're using NIH money, you need to travel with certain airlines. So I would say those are the technicalities that I have found surprising. But otherwise, I am still enjoying the work I'm doing. It is incredibly, incredibly time consuming in so many different ways. Just the logistics of all the work, engaging with the community in an authentic way. It takes a lot of time, but I am still very excited about the work I'm doing. Yeah.
Yes, I echo that, and it's been, for many of us at GSU, just incredibly rewarding. And we've learned so much from all of the groups, all of the new Americans that are in our community. And and you're right, it's hard, it's hard work. To do well and ethically and in partnership with community, and it takes a lot of time. Thank you both so much for this incredibly stimulating, engaging conversation. You both are doing such important work, and I know you're having an incredible impact in your communities. So thank you for that. And I'll just take another kind of quick opportunity to just highlight our next brown bag for February is Mary Bunn. She's at the University of Illinois at Chicago. And she's going to talk about an intervention that's a peer-led family strengthening intervention for refugee families. So she's going to present on that next month. So put a placeholder on your calendars if you're interested. And in the meantime, please visit our website. Please feel free to email me or our PRC website email to be added to our listserv. I'm happy to forward any questions or comments to our presenters if any of our attendees want to email me directly. And so just encourage you to stay in contact with us. And just want to thank both of our presenters again so much for being with us today. I learned so much from both of you. I know our attendees did as well. We appreciate it. Have a great rest of your week and weekend, everyone. And thanks for joining the PRC today. Thanks so much. Bye-bye.